Aziza Ahmed at Northeastern University Law School, Dr. Abrar Karan, and Dr. Yvette Gosier. So I want to start by acknowledging the fact that this panel, while it is about global public health, really seeks to explore the ways in which global public health is far more, or questions of public health are far more universal than they first seem to be. These conversations have really important consequences for our discussions on incarceration, detention, inequities, racial, gendered, and otherwise. And so to that extent, I want to give a quick shout out to the Lear Institute of Human Security at the Fletcher School that has been putting on similar programming through its Intersecting Pandemics, Detention, and Labor in the Times of COVID speaker series. And without further ado, let's get started. Thank you for bearing with our technical difficulties. I wanted to begin by asking each one of our panelists to sort of provide an autobiography of themselves, because you'll be able to explain your work far better than I could. And I'd love to ask, what does decoloniality or even coloniality as it pertains to global public health mean to you? And what has it meant for your career and your trajectories up until this point? I'd love to start with Professor Ahmed on this.
Thank you so much, Neha, and to all the organizers. This is inspiring to see you guys come together to reframe some of the big issues that we're thinking about in terms of decolonization and race, and making it harder to talk about and in all the right ways. Like Neha said, I'm Aziza. My name is Aziza Ahmed. I teach at Northeastern University School of Law. I'm a law professor, and so I think a lot about the role of law in development and also in healthcare. And my work focuses on feminist activism in the global South and in the global North, in the United States in particular. And I'm interested in how feminist activists have reshaped the global health space and the US healthcare system on issues of abortion, sex work, trafficking, birth control, and HIV, among other issues. When I hear, just to sort of focus in on Neha's question, when I hear the topic decolonization and global public health, and I think about my own work in that space, I tend to think about two specific dynamics that I work on. One is decline of capacity at the national level, which can be attributed to global forces. And so that's in some ways an extractive way that national governments and countries have to grapple with their relationship to the global, especially in aid receiving countries. And in this sense, I might think about the structural determinants of the social and structural determinants of health that shape health outcomes. And I would include, when I'm thinking about this in the global context, structural adjustment programs, go back to the 80s, to the Bretton Woods institutions, which limited public health spending, which caused the decimation of national public health infrastructure and health infrastructure in general. And we can see how how people's lives and governments have fared in the context of epidemics following the 1980s, with Ebola, with AIDS, with Zika, as countries really struggle to address their public health needs. And of course, and this is something I'm writing about now, I'm working on a book on feminist activists in the US who work to change the CDC definition of AIDS. We saw this in the US as well in the 1980s with the rise of neoliberalism, of course, structural adjustment being part of that story, but the rise of neoliberalism and the decline of social services for people, especially poor people. The second aspect of when I think about coloniality or decolonization, empire, in the context of development, I think a lot about how we see the reproduction of international hierarchies through global public health infrastructure specifically. And we see this in the context of development assistance. We see this in the context of aid conditions. We see this in US foreign policy. One a small piece of this is an example that I've written about is the President's Emergency Plan for AIDS Relief, which was passed in 2003, and had within it provisions that mandated that organizations receiving U.S. dollars could not advocate for the decriminalization of prostitution or sex trafficking, and they also had to sign a pledge that said that they would take the U.S. government position essentially on sex trafficking. Now, because the U.S. government conflates sex work with sex trafficking, it meant that the U.S. government was basically funding projects that undermined what public health experts really felt was the best way forward, which was harm reduction. And sex workers were so integral to the harm reduction paradigm in the AIDS context. Now, this is a complicated story when we think about this as a story of told in the context of a decolonization frame or in the colonization frame, because feminists lined up on both sides of this fight, some siding with the US government, some siding with harm reduction and public health experts. And on both sides of that were feminists from the global South and the global North. So it complicates the way we think about these relationships. And then I'll just add, because I'm a lawyer and someone who thinks, this is from a legal perspective as well, that part of that story is also thinking about how US courts and US institutions play a role in actually adjudicating the kinds of things that people can advocate for around the world and really demand from their own governments. And what we see in the PEPFAR context is, and what we see actually in the, hopefully this will change, hopefully if Biden and Kamala Harris win, but yeah, exactly. But if they don't, we'll see this continued with the global gag rule. So we see how the US government actually is disabling activists and advocates in their home countries from actually making the kind of national level change they want to. But I'll stop there.
Thank you so much, Professor Ahmed. And I would be remiss if I didn't say that your work has been a huge inspiration to my capstone that I was working on over the summer. I highly recommend everybody check out Professor Ahmed's work. And this sort of neoliberalism as sort of setting the global public health agenda is not a new phenomenon. In fact, it's been part and parcel of global public health in general. And I think this segues pretty neatly. Dr. Kern, if you are a physician, but you also have a background in political science and decoloniality in general, same question, if you could sketch me an autobiography along these themes, that would be awesome.
Yeah, absolutely. Thank you, Neha, and all the organizers. When I first got this email that you guys were doing this conference, I was really, really thrilled to see this as a focus point, because when I started working in global health, this is now 12, 13 years ago, certainly as we were sort of thinking about it at that time, this was not the forefront. It took actually a long time. It was a long process for me to really even understand sort of what my own role was going to be within global health. And I'll take it a little bit more personal. So, my background, I was born in India. My family's originally from Hyderabad, India. And I actually spent a lot of my time growing up in Los Angeles, and we would kind of go back and forth through the summer, which is probably a common story for a lot of sort of first generation immigrants to the US. And a lot of my childhood was sort of seeing what was going on from the perspective of someone that didn't live in India, but was sort of witnessing some removed version of what poverty was and what people were really going through in these sort of very dire circumstances. And, I'd spend a lot of that time with family and cousins and whatnot, but the questions in my own head were always kind of there, which was to say, what was the difference between me and somebody that I was seeing that was extremely poor, asking for money or knocking on the window of a car. And that question was actually really what pushed me to think about doing more work in global health. So in 2008, that was kind of my initial foray, where I kind of grew up speaking Hindi and Spanish because sort of a more complicated personal background, but I ended up being a translator for Spanish to some doctors that were working in the mountains of Dominican Republic. And I remember we used to take these flatbed trucks out into the mountains where we were setting up these clinics to sort of treat whatever we could in this sort of remote area. But the main question that came back over and over again is what happens when these sort of makeshift clinics are not there? Do people get sick again? And the answer was yes. And it was why? Why are people getting sick again? And what were the limitations of clinical medicine? So where did the boundaries of clinical medicine end or start to overlap with other fields? And that's actually where my interest in political science came from, where it was really what were the political structures in play, and from that, what were the historical structures in play that created these inequities and perpetuated these inequities? And were these systems actually really designed to help people, or were these systems designed to stay in place? And was actually that inequity what drives global health? The lack of equity sort of gives people something to do. That's one way to look at it, and maybe that's a pessimistic way, but as I kind of went further along, even more recently, I work at Brigham and Women's Hospital now clinically, and then we're very tied in with Partners in Health, which is sort of the NGO that kind of does some of the more implementation side of some of the global health work that we do. And so I remember just a couple of years ago, we were in Haiti, and Dr. Joya Mukherjee was sort of setting the stage for how we think about global health. And she brought up, you can't be a student of global health if you don't understand the history of global health. And, as Dr. Ahmed brought up, things like structural adjustment grants and these systems that were sort of political, economic, social, that actually really created a lot of the global health inequities, or made sure that they stayed as they were, that we see today. And so then you really start to wonder, well, what am I doing within this system? What role do I play within this system? And, it's funny that Dr. Ahmed brought up PEPFAR. So in 2010, my sort of thesis project that I was working in Uganda clinically at the Infectious Disease Institute. And I was doing my political science thesis, which was, what was Uganda's response going to be if PEPFAR funding flatlined? And it made me really sort of think about what was the role of sort of international donors, and how do those setups, financial and otherwise, really dictate what's happening on the ground level. I was talking to people in clinics, talking to patients. If you can't get access to ARVs, what does this mean for you? What did Uganda have to do in the 1990s to sort of get around this before they had funding or antiretroviral access, et cetera? And, I think there's so much to be said here, and I can go on, but I would basically say that one of the things for me, as I think about where does neocolonialism play, is what role do we individually play as students or physicians or whatever profession we take in perpetuating those forces without realizing it, without even knowing the harm that we're doing. Because whether or not you realize it, you very well could become an actor that allows it to continue happening, because that's the way the system is designed. And that's actually something I've been thinking a lot about pre-COVID. I'd written a few pieces about it from that perspective, but we can kind of get more into it. But I'll leave it at that.
Excellent. Thank you so much. And one of the things that you mentioned about, what role do we play knowingly or unknowingly in sort of further entrenching a lot of the assumptions upon which the global public health and indeed our sort of national public health structures are created. Dr. Cozier, a lot of your work deals with the sort of differential health outcomes, or like the ways in which health is issues of public health are almost predetermined for certain groups in the United States, obviously African Americans being foremost amongst them. In what I'd love to get an answer to the same question from you, but also touching on the ways in which we do knowingly participate in these structures, understanding that we've heard horror stories, frankly, of patients from certain ethnic or racial backgrounds almost being left to hospice care when they go into a hospital for COVID treatment, where they could have had the same health outcomes as somebody else from a more privileged racial or ethnic background. That was a sloppy segue, but I hope you'll make the most of it.
Sure. Can you hear me okay? You just want to make sure.
Perfect.
Can you hear me? Okay, great. So thanks for the invitation, certainly. And just as by way of a brief background, I'm an epidemiologist. I'm a social epidemiologist in particular, in that the structural determinants of health are really the only lens that I see epidemiology through. So this involves, just constructions of race, community, which is built often on race and identity, and where people live and the resources that are made available to them. My work focuses primarily, almost exclusively, on domestic populations within the U.S. And like the previous speaker, I am the daughter of an immigrant parent, so I spent much of my youth and even my adulthood going back and forth to another country where it helped to sort of shape my views. And seeing the structures of the colonial structures as they continue to play out, even in populations that are that are independent. But so I just want to just to follow on that previous theme. One of the things that I see in the global sense is the distribution of food and what food is made available. And I think that has a lot of application domestically as to the distribution of food and what is made available in certain communities. So, it's only in America that I can see that even in a rural community where food is grown and produced, that you still have these incredible pockets of poverty and food insecurity and dependence on food that is neither coming straight out of the ground, but is very processed. And this holds true in rural communities as well as inner city communities. And even in international contexts, I like to go into the supermarket in any country that I'm in and get a sense of what is there. And, the moment that I see American spaghetti sauce in a place that it would not normally be, I understand the forces that help determine, the food that's available for those individuals who live there, and it's usually not a good picture. To get to your question about how COVID has played out and how it's affected various departments. I could talk about COVID for a long time, but COVID was really a perfect storm that laid bare the U.S. Healthcare system, largely, unless you are, you have an access to a high level of care, you are likely to come into that care earlier in your process so that your outcomes are maximized. One of the things that has really put a spotlight to the inequities within this country around COVID was a report that just came out from the Department of Public Health here in Massachusetts, where I am. Sorry, that's my dog outside. And that is that where COVID testing is available in the highest proportions is not where the risk is highest. So communities of color, where you have front line workers, where you have individuals, more crowded housing, less ability to exposed, the testing in those areas is a fraction of what it is in a neighboring community where the median household income is twice that. There is testing for days in those communities. Similarly, within workplace, I work at a university that runs a very well oiled machine when it comes to testing. I'm tested all the time. But I could also say that my risk is relatively low. So just in the distribution of those types of resources has resulted in who makes it into the hospital first. If you have symptoms but no test, that determined often, who was sent home or who was admitted. to some degree. So I'll stop there for now and hope that addressed the issues that you wanted me to at this point. But I look forward to the furthering the conversation with the rest of the panelists.
Absolutely. And we'll definitely be going back to this theme since it brings out, as you said, it lays bare so many of the inequities that have been baked into the public health system in the United States. But just to bring it back home to Fletcher, I wanted to ask very broadly if you could, and I think Dr. Curran and Professor Ahmed, you did talk about this, and so you're welcome to either truncate your answer or spin it into something else. What makes global public health an international relations issue? I don't know that people traditionally have equated the two. So what is it that makes these two topics salient in either comparing them or in using one to shed light on the other? And Professor Ahmed, if we could start with you.
Sure. Well, I don't see how we can see the two separate from each other. So I hopefully I can answer the question of how they are together. But to me, the really obvious thing from my vantage point, from someone who works on issues of gender and health and reproduction and sexuality, is the very fact that the US government is the largest funder. It's the largest bilateral donor on issues of AIDS, on issues of family planning, on issues of reproductive health, on issues of gender, which means that the entire aid receiving world is somehow impacted by US dollars. And I don't think that's necessarily a good thing. I think we really need to critically interrogate that type of relationship, which is why a conversation like this is so exciting. It's important too, because our legal norms, although we often talk about the legal system as though it is value free, of course, living in our contemporary moment, that's very clear that it's not value free, but in that we think about the legal system as something that is value free, it kind of masks the way that US actors actually shape how that money is spent, how that money is actually given to organizations, what organizations receive USAID dollars. And this immediately makes it an issue of international relations. That, of course, is separate from the very fact of the human bodies that are impacted by and managed by the entire system of international law, migration, and of course, traveling of a virus that doesn't really stop at borders. But even just from a very formal IR perspective, I think there's a lot to interrogate about the way US foreign policy works and who the actors are that are actually shaping how those dollars reach people on the ground and shape public health programs.
I think that's also really important, the idea that public health is something that isn't necessarily constrained by borders, but humans are. And what does that mean when we're trying to create a truly, global response to a global pandemic? Dr. Curran, same question.
Yeah, no, I mean, I think that COVID is really a perfect example for anybody that would question whether global health is an international relations issue, right? So a viral pandemic, a viral disease like this touches on every single aspect, including security, including travel, including economics, including the sharing of information, clinical and otherwise, across borders, including sort of cultural perceptions of different countries and how that kind of impacts the way that people will engage with one another. Right now, the world is sort of watching as we have a pandemic in our country that's completely out of control. In a country that very much, in my opinion, at least because of neocolonial forces, was expected to do so well and control this so well. And we've done actually exactly the opposite. I would argue we have the worst epidemic response in the world relative to the resources and perceived expertise that we had. And so I think that this is really a perfect example of how health really touches on all of these other aspects. And I think this is a question that you may touch on later, but one of the most misunderstood aspects, in my opinion, of public health is that it's sort of these very traditional aspects related to sort of clinical medicine or sort of very foundational epidemiology. And actually, the more you sort of study history and look more deeply at epidemics, you actually see how all of these other forces play in very, very important ways, political, anthropological, economic, et cetera. So I really think that COVID is a great example of why these two are so deeply tied.
Absolutely. That's I hadn't actually thought about how even our assumptions that the United States by rights should have done well is itself a sort of relic of its status as neo-colonial power par excellence. Thank you. I'll be sitting with that for a while. Dr. Cozier? You are muted, Dr. Cozier.
Unmute.
Excellent.
Can you hear me now? Great, great. So I think, again, my work is domestic, and but I would say that, like my co-panelists have alluded to, is you cannot have, well, okay, so just putting this back in the perspective of COVID, to stay with that example, is it is impossible to have economic health without public health. We have tried it, it's not working. When we focus only on the economy, the infection gets out of control, and the effects of addressing the infection do have effects on the economy. So the same is true, I think, with international relations. There is no country or entity or place that the U.S., just as like a major leader in this field, can go without paying full attention to the conditions on the ground. It cannot, as was just said, it cannot, think that you will deal with trade and not be able to address the health implications of trade, given that health inequities exist in a large way. So public health is really part of a well-functioning democracy. I think where people don't understand public health is that it does reach all of those areas. It is an economic force. It is a undergirding of a political system. It is, it undergirds education. Public health is not simply vaccines and building hospitals, but those are certainly important within a global system to operate well. And one of the things that we've seen in our response to COVID, again, I do like the phrase that was just used, that it was expected that the U.S. would have had the best response to this, but we clearly did not. But part of our response was to destroy public health, to discredit public health, to discredit science. So how on earth can we have had a decent response? And with that, we've seen the economic downturn. But until we recognize that this is all part of the same, different sides of the same coin, we will not, we'll end up in the same issue and problem that we're in right now for a long time.
One of the most sort of jarring discourses that has come out of this entire experience, beginning in March and especially more salient over the last few months, has been exactly this dichotomizing of the economy on the one hand and public health on the other. And I think that's a very dangerous way to view anything. If you put bodies on one side and money on the other, that's not sustainable, nor is it necessarily humane. And I think that is a consequence of the neoliberal system and the way it's trickled down and penetrated every single country, especially this country. And so, Professor Ahmed, one of the questions that came out of, and actually let me preface by saying here that our viewers are more than welcome to toss in any questions that come up during the course of this conversation in the chat. We'll try our best to get to all of your questions. And so one of the questions that has come out based on the earlier comments made by Professor Ahmed about the Bretton Woods Institution and structural adjustment, to what extent is this state of affairs still true? Are the IMF and the World Bank still barriers to global health investment? If they aren't barriers or have weakened, was this a result of internal or external changes? And ultimately, how can we work to encourage global health investment, especially with or through international institutions and organizations? And this was relevant to to Professor Ahmed's earlier comments, but everybody else is welcome to chime in as well. Professor Ahmed, starting from you. I think we have to manually unmute you 1 sec. We have been Zoom bombed in other rooms, so we're trying to be extra safe.
Okay, thank you. Yeah, so I think that there are a lot of people at the World Bank and IMF who are trying to do the right thing now. I just spoke to a panel at the World Bank on some of the legal issues, that COVID is creating in country and how we might begin to approach those issues. And, it's everything from privacy to data, health data, clinical trials. And so, there is a way that there are people in the institutions that are trying to do the right thing. But I think that the institutions themselves, the World Bank and the IMF, set into motion such a huge dismantling of such a huge sort of reorganizing of the economy that led to failing public health systems, that it's difficult to really see how it's not currently at play. I mean, my own work focuses on the U.S. government, and certainly the U.S. government is very much still in the mode of neoliberalism. It's very much in the mode of individual responsibility. I think in the context of global public health, one of the places we see this the most clearly, and this is also true in what's going on in the United States with our own healthcare debates, is with the use of user fees or co-pays with access to healthcare, and with user fees in the developing country context, we saw a huge decline in the ability and capacity of people to access healthcare services. We see in the United States rising rates of bankruptcy due to healthcare costs and inability to pay for healthcare. So some of those, I can't really speak to the specifics of how the World Bank and the IMF are today sort of implicated in global health programs with the same specificity that I could actually about the 1980s. But I can say that the ideologies that drove those early programs are still very much in play, and they're very much undermining our capacity to actually provide healthcare services for people.
Dr. Kern? Sorry, 1 second. Here we go.
Thank you. Yeah, I'm not sure that I'll have much to add beyond what Dr. Ahmed said, in the sense that I'm not sort of working as closely with World Bank or IMF right now. But, there actually is a question in the chat that I thought might be relevant to address, which is from Earl, sort of talking about the fact that some sort of communities may have access to testing for COVID, but don't have sort of trust in the system. And in that way, how do we sort of decolonialize in the community setting? And I think this is really, really, really an important point. A lot of the sort of work I had done in global health earlier on was actually just sort of spending time with people on the ground. And I think that there's a serious disconnect between sort of academia, even the hospital, clinical medicine, and the patients that we take care of. This is very different. And I think it becomes more and more obvious as you think about even the systems that create medical professionals and what advantages you have socioeconomically and otherwise to even become a doctor or a nurse or a PA or whatever in this system. I can say that a lot of the patients that we take care of come from very different backgrounds, very different understandings of the health system, much perhaps justifiably lower levels of trust in the health system. And so one thing that came up over and over with COVID was trying to really understand what people were dealing with on the ground, people in communities that were truly suffering. And so you heard this phrase like everyone stay home, stay home. It was sort of naive to say that, and yet it was easy for a lot of doctors and professionals to say that. But a lot of the people that were frontline workers could just not afford to stay home. A lot of the patients that I was taking care of in the emergency room in April were people that could not afford to stay home without the necessary relief packages or economic support that they needed. And so I think it really sheds a light on how disconnected academia or elitist academic institutions are from the sort of communities that they're supposed to be serving, supposed to be working with. And that, I think that divide needs to be bridged. There's multiple ways that happens, but I think that getting very deeply integrated into community settings is part of that. And you'll notice if you work in an academic institution, people really have to try to even set up bridging that divide in a way that fits with funding, like research. So one way to sort of get into the community would be to create a sort of research study around it, so that you're bringing in money for the institution or the hospital, whatever, and then you can do community work. And I think that's a problem, right? I think that we pay a lot of lip service to sort of fighting inequity. And yet fighting inequity is not actually structurally rewarded in a lot of the systems that we function in as clinicians, as people in academia, et cetera. And so again, if you sort of deep dive into these disconnects, you realize that a lot of it's a very much a disconnect at the ground level, just amongst people and amongst understanding between people.
I think that's really important, especially you mentioned repairing distrust and this idea the healthcare system purports to serve are not naive. They often have a sophisticated sense of where the money is coming from, and the fact that there is money at all heavily prejudices people's ability to have a lot of faith in the people who are trying to help them, be it for out of goodwill, and very often it is goodwill. And so, Dr. Cozier, since that question was initially directed at you, I'd also love to hear, if you're comfortable, how do we ask communities that have traditionally and historically really been maligned by the healthcare system, such that the healthcare system was set up to disfavor them, Black Americans, especially Indigenous peoples? How do we ask them? How do we begin to broach that conversation of repairing trust?
Yeah, that's a very good question. And following Dr. Karen's comments, about those of us who are, privileged and work in the academy or in healthcare delivery, moving into the community, that's further exacerbated because you actually see a lot of much of a race and class discordance with who's coming in versus who lives in the community. So that is something that is going to be a lingering problem until we start to have greater representation within the healthcare workforce. Another, in response to the comment in the chat box, is that that not everyone in the community avails themselves to the testing. Some of that could be true, but again, if we take a step back and look at the structural determinants, where testing is available in high-risk communities, again, it is not available in the same proportion, in the same amount that it is in the low-risk communities. So walking into, say, West Roxbury, which is one of the neighborhoods of Boston, to get this testing, there's a good chance you're going to probably be in line about 10 minutes in and out. If you go over to Roxbury, where it is also available, but in fewer places, you might be there for a whole hour. You might be there for a couple of hours. If you don't have that time off from work, or you don't have a place to have your kids watched while you stand in line, or if you have to bring them with you, that is as much a barrier as blocking the entrance. And we can take that same situation and apply it to the election system, right? We're seeing where either ballot drop boxes were being removed, so there was one in an entire county, or a few polling places where people had to stand in line for hours and hours. If testing becomes as cumbersome as that, we have to question, why are people not making themselves available to the testing? And I would be much more willing to put it on the part of the structures and its availability. To the other point of that is a conversation that has slowly begun to emerge, and it represents good intentions, yet sort of widening inequities. And I guess akin to what was said a little earlier about how the World Bank and IMF mean well, but they still kind of reinforce these structures. And that is around who, presuming we have a vaccine that is safe and presuming that it's even found to be effective, who gets in line first? So there was a conversation begun by people who were very much well-intentioned, saying, well, it should be the same marginalized communities. They should be in line first to get a vaccine. If you know anything about history at all, and if you've paid attention, you recognize those same communities may not feel quite as good about that as the people who are making the suggestion. When something, when you've been marginalized for so long, but all of a sudden, this new experimental thing, and it's your arm that, your sleeve that gets rolled up first, and you're the one who gets the injection, there's a little bit of side eye that goes on with that. And, and with good cause. People want to know, wait a minute, is this because you don't know how the vaccine is going to work? And what if there is a problem? You have no problem injecting communities of color? Or is it because you want us to be healthy so that we can get out there and continue to work, keeping your economy floating while we get not much? So it's important to understand the history and all that goes in it. And if you want to get this to the community first, a good listening tour, go in the community and sit down and say, what is it that you want from this process? And that's the part that takes the investment, takes the time, that is not often compensated on the researcher side or on the public health side. And that would make the much more the greater uptake in potential services. So history and context are everything when it comes to public health.
That's really helpful. And I think, I've personally been guilty of saying, well, the priority, once there is a vaccine available, once we have some mitigating strategies available, should be the communities that are most adversely affected or disproportionately affected. But you're absolutely right. There's a rich history of intent versus impact at play here, and that is a massive barrier to surmount. And this is this is something that has been touched on in the conversation thus far. And here I do want to be mindful of time. We know that the COVID-19 pandemic has disproportionately affected vulnerable populations. And we know that not just pandemics, but other public health issues, HIV, AIDS, right, venereal disease, even, a lot of these issues have disproportionately affected communities are vulnerable in other ways. And so in that sense, public health cannot be stripped away from the other forms of oppression that contaminated society. I did not mean to say contaminate, excuse the pun. And I'll start with Dr. Kern here. What are some of the more insidious ways in which the COVID-19 pandemic has affected certain populations? And when I say insidious, of course, we have been talking about African Americans in general, but have you noticed in your practice other sort of less observed or talked about ways in which people have been affected?
Yeah, so what I think is actually most surprising, and this is I'm quoting a colleague of mine who we had a conversation about this a long time ago, is that people were surprised at all the way that the virus spread. If we paid attention, or if we gave any sort of deliberate intention towards addressing inequities before, it was quite predictable that frontline workers, people of color, people who didn't have access to the healthcare system for a lot of reasons, including structural violences that have thus led to them having comorbidities, less access to care, et cetera, that these were the people that were going to be harmed the most from any sort of disease like COVID or otherwise. And the fact that there were a lot of people acting surprised about this says that either those people weren't paying attention, or that those people were not, or that those people were sort of functioning within the system again, unknowingly sort of perpetuating this inequity even before COVID. So, a few of the things that we saw when I was taking care of patients in April in the COVID emergency room at Brigham and Women's Hospital, most of the patients that I was seeing were patients of color who were frontline workers. Many of them lived in very crowded housing. They were not able to safely isolate, right? They were not able to safely quarantine. A lot of them were infected from people that they knew. They said, my mom was infected, but there's nowhere for her to go. She can stay in the living room, but that was it. And now everybody's sick at our home. I had some patients, there are tragedies, a lot of tragedies. I had one patient I took care of, him and his father, both, and his mother, actually, they all got sick around the same time. This was a patient of color, and his father was, extremely ill and in an intensive care unit, and he was being taken care of by me in an emergency room, and he wasn't even able to be at the bedside, with his own family member. Again, though, this is not surprising, right? These are inequities that existed. The setup was already there. All it took was a match being lighted for this to go off the way it did. And so I'd say that to be surprised that this happened just means that you weren't really paying attention to what had been set up prior.
Yeah.
Dr. Gozzi, if you want to chime in on that, by all means.
Yeah, no, I agree with that. When thinking about the other things that have not been discussed and brought up, and the U.S., we are unique as an industrialized country that in which, like, one of the number one reasons for bankruptcy is because of medical bills in this country. We can't agree on healthcare coverage as a nation, and yet we are in the middle of a pandemic in which previously very healthy people could end up spending a good stint in intensive care. And even I look at, again, from in the context of an earlier question, being in a more, quote unquote, privileged class, I have decent health insurance. However, I also know that on a Cadillac plan, if I have to pay 10 or 20% of the overall bill, and I spent 30 days in ICU on a ventilator, right, that's a lot of money. That's a lot of debt to carry as an individual. And we have not even begun to consider that. So we have, rightfully focused on poorer communities. But the middle class is going to take a big hollowing out from this as well. And that is something that gets very little discussion. And it's something that concerns me quite a bit.
Thank you. That is definitely something worth losing a little bit of sleep over, I think. Professor Ahmed, one of the things that I'm interested in as well is the sort of people who we don't consider in a lot of these discourses. I know a lot of your research has focused on sex workers, and I know, especially, I'm Pakistani, I grew up in Pakistan, and one of the things that I have seen is how, especially in our third gender community, our transgender community, for whom a lot of whose livelihoods hinge on the availability of sex work, they have had to choose between their livelihoods or just the ability to survive or COVID. And they have chosen just the ability to survive. And of course, COVID is not the only danger they can expose themselves to, as it is, especially in Pakistan, but everywhere really. There are a lot of structural inequities that preclude sex workers from being able to practice engage in their labor in a safe way. Have you seen or heard of the ways in which COVID may have exacerbated those structural inequities?
Yeah, absolutely. I mean, I think when we're talking about anyone working in the informal economy, sex workers being a good example of this, we are in a situation in which people's livelihoods are being extremely disrupted. And I just, on the point of sex work and in the informal economy as well, is the issue of criminalization and the way that the criminal laws actually map on top of some of the public health laws to exacerbate what is already a very precarious way of earning money. And when we think about bankruptcy and financial instability and financial precarity, again, we're talking about informal workers. In the context of sex work, it's especially scary because in the AIDS context, sex work was, of course, a very high risk activity because HIV is spread through sexual intercourse. But with COVID, even in some ways, even more so, simply because of the close contact and because of the huge anti-trafficking push, a lot of other avenues, a lot of online avenues and other ways of advertising services and actually meeting with potential clients have been shut off for people. People become even more precarious once again. So, it's a really, for sex workers in particular, but I would say for informal workers in general, it's a very precarious situation. And of course, the gig economy, has created a set of vulnerabilities and a set of points of contact that have exposed people to the virus. We saw this with the debates around Uber and Instacart and Amazon delivery workers, and so the many, many people who were basically pushed into the labor force to make up for the fact that their other employment had closed. I'm just writing a paper on the fact that many of the people who suffered through this are Black and Latina women, women who are heading up their households, who have no ability to stay home and no ability to protect themselves at work. All of this in the context, as Dr. Karan said, where in which the home sometimes became even sort of a tragically dangerous place for people in the context of the virus. And so there's so many issues that come up when we think about how informal labor and informal works, informal markets kind of come into contact with this virus. You also mentioned the trans community, and I just wanted to say that, when we talk about specific communities, we also have to think about all of those ways that the various social determinants of health, like housing, lack of employment, discrimination, racism, distrust of the medical system, racism within the medical system, and in the workplace, all make people vulnerable to contracting coronavirus and really to poor health in general. So.
Thank you. That was definitely very helpful. I think since we are about 10 minutes away from the end of the panel, I wanted to, we're lucky that amongst our participants, we have a pretty diverse array of students, academics, practitioners. And it may seem like a simple question, but I hope it is an effective question. What can the people at this panel take away from this conversation? How can we internalize a decolonial mindset to global public health, or even just domestic public health? How can we operationalize some of the conversations that we've been having over the last hour and a little and a half hour? I don't know, time doesn't exist. And I'd love to start with Professor Emmett, then Dr. Karan, then Dr. Gosier, and hopefully that should get us into our happy hour that's coming next.
Well, I would say following along things that Dr. Gosier and Dr. Karan have said, that we should place communities at the center, place people at the center of our response, and if we do that, then we can see, at least in the legal context, we can see how law might flow from that. So for example, if you centered the life of a sex worker or a trans person in Pakistan, or people who are living at the margins, although in this crisis it doesn't really seem like these communities are at the margins, they're actually quite in the center. We can build out a legal system that's more responsive to the particular needs of bringing stability, bringing housing stability, trying to address issues of discrimination, making sure that people have adequate access to healthcare and medication. And I think a lot of that is recentering the people who are being most affected. Like Dr. Crozier said, looking at who actually needs the testing, where is testing actually being delivered, and really trying to keep a critical eye on what's being said and done in the name of public health. Because although public health is, in the last 10 years, maybe pre-COVID, maybe COVID is going to change, this has become this way, almost like a default, like, oh, we need to address what's going on with XYZ issue, violence against women. Let's take a public health perspective. Well, this COVID crisis is revealing that public health has a lot of problems that we need to interrogate too. And so I would say those two things.
I've heard people talk about taking a public health approach to countering violent extremism, which brings
Right.
with it a whole slew of issues. So yeah.
Exactly.
Dr. Curran?
Thank you. Thanks so much. And I would say that for me, at least, the biggest takeaways have really been understanding history and context. So, as we sort of work within global health, or even as we work clinically within the hospital, I think one of the most important things is just understanding contextually what the relationships are and the dynamics are with the people that we're working with. So let me say I'm seeing a patient. How does that patient perceive me? How does that patient perceive the medical system? And what sort of limitations or barriers are sort of created within that? I think that perceptions and context are so critical. And the time that was most notable to me was actually when I had gone in 2008, and I was working in India with a number of other students who were of American background. And I was this kid who was basically kind of like half Indian, half American, where I at least understood the local context. And it was such a strange experience to see the way that that my colleagues who are American perceived Indian culture, and the way that Indian people perceive these people, and the sort of weird role I played in between those two. And I could understand a lot of these strange nuances that were coming out and what was lost in translation. And that was an experience that always really stuck with me, because it then made me think, a lot of the misperceptions that were happening, people didn't realize they were happening. They didn't realize they were being perceived in a certain way. And then it made me think, when I'm working in communities where I'm of a different background, and I'm coming from America, for instance, even that power dynamic is something that's extremely complicated. And you really need to think to yourself, before you engage with community work, what is the historical context? How might I be perceived? And how might I approach this in a healthier way to even those power dynamics out, and sort of recenter where leadership is within whatever you're working in. So I would just leave with that.
Thank you. That's very helpful. Dr. Crozier?
I agree with everything that's been said. And I guess what comes to mind is being collaborative. That lawyers and epidemiologists and economists and physicians, we all bring a little bit to the table, and we can certainly work together. But importantly, recognize that collaboration really needs to also include members of the community. It's great when we sit down and we find that we have great overlap, and that we complement each other with our different approaches and techniques. But until and unless we have representation from the community at the table to say, this is what we need, it won't get anywhere. Just a quick example of where I really found that this is important, and that is just, again, in the United States, In urban areas and even in some suburban areas, sidewalks are important. We like sidewalks. We think that this is necessary for safety. You go into rural communities, you don't see a lot of sidewalks, and it's very easy to say, oh, these poor people, they're such at risk, because they will walk along the rural routes. If you ask the community what they think is important, sidewalks is pretty neutral. That's really not something that comes to their mind. That's not what they will identify as being important to their health. They know that when they walk along the rural route, that the traffic, whether it's coming at you or from behind you, will drive right around you, give you great berth, because that's the norm there. But if I come there with my city perspective, I'm going to be, trying to get money to get a sidewalk put in place. That really isn't going to make any difference. So having people from the community actually sit down with you and tell you what it is they feel they need and how they can best become agents in their own health and preservation is very important.
Thank you so much. I'm not personally a global public health specialist whatsoever. I sort of accidentally found myself in this realm. And I think, in fairness, we've all accidentally found ourselves in this realm, given the events of the past year. And I wish, in a sense, that we had all found ourselves in this realm sooner. Thank you so much for a fantastic conversation. I hope that the attendees got as much out of it as I did, and I'll be sitting with this for a long time, and I hope everybody else will as well. Thank you, Dr. Gosier. Thank you, Dr. Curran. Thank you, Professor Ahmed. And I really appreciate you joining us. To our attendees, we are opening up to a little happy hour to help end the evening. Make sure you come back tomorrow for the rest of our programming. We have 3 workshops and our remaining panels all happening. Our program is at bit.ly/DIR program, capital DIRP. That's bit.ly. I'm just going to put that in the thing. Don't worry about it. And with that, feel free to join our happy hour. Link is in the chat. Thank you all. Take good care of yourselves.
Thank you. Thank you. Bye-bye.
Bye.
There we go.
If you missed it, the link to the main room /happy hour is bit.ly/DIR main room. We're going to drop that back in so you know where to go.